grateful to be able to have that and excited to talk about some pediatric cases today as well as some adult cases. So again, welcome everyone, and we can go ahead on to the next slide. Thanks. So on today's agenda, we're going to include, of course, some general announcements and introductions as we generally do, a didactic presentation on when genotype and fibrosis matter in children by Dr. Alfaro Cruz, and then a pediatric case presentation, adult case presentation, and then of course our hot topics and closing remarks. There we go. That's the right view, Lindsay.
Okay.
Thanks. First, some quick reminders for those of you that are interested in continuing education. It's really, and even those of you that are not, there's a lot of great resources offered through Southeast Age Education and Training Center. So please use this QR code or this link to make sure that you are registered for this session through Southeast Age Education and Training Center as well. It'll open up access to a lot more resources too. So Anastasia just dropped the link in the chat. So thank you, Anastasia. So first, we're going to start with some in-chat introductions as well as some brief announcements. Before we get started, I'd like everyone to take a second, introduce yourselves in the chat. Let us know your name, your role, what organization you're with, and whether or not this is your first echo session with us. And if you're having any difficulties, you should see Anastasia Cahigo in the chat as well as on your screens, and she can help with any technological issues. Seeing a couple of introductions. Happy to see folks joining. And it looks like we have I know at least a couple people that this is their first session, so really excited to have you. Thanks for joining us today. So we are going to get started with Dr. Alfaro Cruz sharing information on genotyping and fibrosis in children. So Dr. Alfaro Cruz, I will pass it over to you.
Thank you, Mia, and happy to be here today so we can talk more about when genotype and fibrosis matters in children. Next slide, please. So let's start, but I don't have any financial disclosures or conflicts of interest to report. Next slide, please. So we've talked about why Hep C is so important and why we are actually including pediatric in our ECHO platform, right? So we know that we have at least 115 million people infected in the world with Hep C, that of those, about 11 million are actually less than 15 years of age. And we know that if we don't treat chronic Hep C infection can actually lead to very severe liver disease and other complications that can actually increase the mortality and morbidity of the patients. Next slide, please. So when we talked about liver disease, let's start by talking about cirrhosis. So we've talked about this a little bit in previous sessions, but it's important to kind of remember that this is a diffuse process that is characterized by fibrosis and nodular regeneration. These can lead to the disorganization of the liver architecture, where you have a healthy liver, as you can see in this picture right here, that starts becoming more and more damaged with time, leading to fibrosis, where it's going to go to scarring of the liver. Then that can result in cirrhosis and potentially severe liver disease or liver failure. Next slide, please. So when we talked about this, we know that the hepatic fibrosis scores actually tend to increase with age. In the past, and this is actually very common, we know that Hep C-related liver disease usually is not common to happen or occur in children. Actually, different studies have shown that only 2% of sample of patients in a total of 360 patients with Hep C did present some kind of cirrhosis before, and the mean age at that time was 10 years of age. Now, when we talked about Hep C and children, we know that advanced liver disease is very uncommon. and it can take up to 30 years after the infection in a child. So that's why we don't usually see these in children less than 10 or 15 or 5 years of age. Now, some cases of cirrhosis have occurred, and they think that those cases may occur early because there are other factors that have been associated with that disease progression. Especially, we tend to see more obesity and fatty liver associated with other viral factors like co-infection with Hep B, HIV, or even in those kids who start actually ingesting alcohol at early ages, then these can actually accelerate the disease progression. So that's something just to be mindful. Now, something that we're talking more and more in pediatrics is the obesity pandemic that we're seeing as early as 5 or 6 years of age. And so that definitely can be a factor that we need to be mindful when we're talking about Hep C and liver disease. Next slide, please. So when we talk about cirrhosis in children, the most common causes usually is biliary atresia. Genetic syndromes like PFIC or metabolic syndromes can associate it with cirrhosis. Viral hepatitis, including Hep C or Hep B, it's not the most common cause of cirrhosis. In fact, it's considered the third more common cause. And autoimmune hepatitis is another common cause of cirrhosis. But as you can see, we tend to look more at biliary atresia, genetic or metabolic etiologies. Next slide, please. So when we talk about symptoms that we need to watch out to see if a kid truly has liver disease, first of all, an upper GI bleed. In a kid, we need to be aware that if suddenly a kid who has Hep C, elevated liver enzymes, concerns for liver disease, start presenting with upper GI bleeding, esophageal varices or gastric varices should be highly in the differential for that kid. Children can present with ascites, hepatic encephalopathy, especially when the disease is very advanced. They can actually also present in liver failure. And we have had cases where the kid did not show anything else and just present in acute liver failure and was found to have cirrhosis. Pulmonary complications in kiddos who have had advanced liver disease can well present. Next slide, please. Signs of chronic liver disease that you have to be mindful, and I think these are very similar as to what we see in adults. Jaundice, ascites, palmar erythema, spider nevi, telangiectasias, gynecomastia, and encephalopathy are very clear things that can happen on chronic liver disease. And this is actually a little bit different as we have talked previously, where we tend to see that Hep C usually in children will not present with any signs or symptoms at all. Kids can be completely asymptomatic and won't show any of the signs. Now, when liver disease has progressed, then we can definitely start seeing some because the liver is actually malfunctioning and will lead to these signs and symptoms. Next slide, please. So we've talked previously also about the direct-acting antiviral medications and what are we using to treat the kids with Hep C. Now, I always put this slide to remind us because the goal that we have right now is to make sure that if we are screening early and we are diagnosing early, we can start treatment as soon as possible. Now that we have these medications, we can actually start treating as soon as they turn 3 years of age. So I really like to always put this slide to remind us that yes, we have medications. We can use them for when they are treatment naive, meaning that they have never received any medication before, even if they have cirrhosis or not cirrhosis, and if cirrhosis is compensated. So you can see here our regimens: glecaprevir, Prevensivir, 8 weeks, sofosbuvir, velpatasvir, 12 weeks, ledipasvir, and sofosbuvir, 12 weeks. Next slide, please. So these are other examples because the question always is, okay, what happened if my kid has cirrhosis? Do I need to treat this patient? Do I need to refer him, or do I have to wait? And so this is kind of a very open area of things that we can do. But one of the things that we need to be mindful is that we don't want to actually delay treatment on these patients. If we know they have cirrhosis and they have failed treatments in the past and their cirrhosis is compensated, we do want to treat. And these are actually the AASLD guidelines regarding of those patients who have been previously exposed to medication and that have failed treatment for certain reasons. And then what can we do, right? And then these actually, it's a very good slide of the different regimens that we have. For example, this one here with lenacapavir and prevensivir, and it tells you about specifically the genotypes. And this is when the genotype matters, because when you checked for a patient with Hep C and you get those initial Hep C PCR RNA, and you get a genotype, we want to make sure we have that information, because that is going to make a difference when we're trying to repeat treatment and use the following regimens. As you can see here, usually with genotype 1, 2, 4, 5, or 6, we can use glecaprevir prevensivir if we had a, for 8 weeks when a child has not exposed to any NS3/4A protease inhibitor in the previous that he has been exposed to sofosbuvir. Then we have treatments for 12 weeks. And then in the case of genotype 3, then if you already have a patient that has failed one of the treatment that has sofosbuvir in the past, then we actually are going to prolong this treatment in order for it to be 16 weeks. So these are actually, and I don't want you to focus as much as that, okay, what are the doses? No, but kind of like what are the options of medications and long duration of treatment, with the goal that we don't delay treatment, even if the patient has failed in the past. Next slide, please. So moving forward with the regimens with glecaprevir and prevensivir, again, we're talking about patients who don't have cirrhosis but have failed previous treatments, or they do have compensated cirrhosis. So even though they have compensated cirrhosis, and we'll talk a little bit more about what we mean by compensated cirrhosis, then you're going to make sure we don't actually delay treatment. And this is an example of those regimens where if there has been a prior exposure to an NS3/4A protease inhibitor, then the treatment they can get is with glecaprevir prevensivir for 12 weeks, and also for 16 weeks, depending on the exposure as well. So a lot of the time we'll have to actually expand the duration of treatments compared to the first initial treatment. Next slide, please. Now, this is another regimen. This is the case when you have had a previous exposure to a regimen that has interferon or sofosbuvir, but no exposure to NS3/4A protease inhibitor. And as you can see, we can repeat the treatments, especially with sofosbuvir, velpatasvir. We can do 12 weeks for all genotypes from 1 to 6. Next slide, please. Now we go forward, and these are the regimens with levetiracetam and sofosbuvir. And as you can see here, these are the cases when they have actually been exposed to either an interferon plus an HCB protease inhibitor regimen. They talked about without cirrhosis and with compensated cirrhosis. So as you can see the difference, especially we're talking about genotype 1. And again, this is when genotype matters, right? In our area, the most common ones we tend to see is genotype 1. But you're going to see the difference between actually having to treat a patient that had already had treatment before, which is only going to be 12 weeks. But if that patient actually has compensated cirrhosis, the length of the treatment goes to 24 weeks. And when we're talking about genotypes 4, 5, or 6, then it doesn't matter without cirrhosis or with compensated cirrhosis, the total time that we're going to use to treat that patient is going to be 12 weeks. Next slide, please. So this is when it comes important. When do we need to refer? We talked about definitely not delaying treatment, and that's kind of one of the main goals. We don't want to delay treatment, but we also need to be aware of, okay, when do we need to actually refer that patient? So any patient that has Hep C, that he has decompensated cirrhosis, and they have a moderate or severe hepatic impairment, and we'll talk about the Child-Turcotte Pugh class. If they're class B or class C, they need to be referred. And they need to be referred to a actually quaternary center that has expertise in conditions, ideally in a liver transplant center, because these patients may qualify, especially if we're talking about decompensated cirrhosis, where they can have portal hypertension, they can have hepatorenal syndrome as well, they may need to actually have further workup and further interventions. And so ideally, we want to refer these patients to a liver transplant center. The other time when we think it's appropriate to refer to a subspecialist or to a quaternary level center is when they have failed multiple times a treatment. You've treated the patient twice, you have proved that they're compliant, but they're showing non-response, then that's when we decide, okay, let's refer, because we may have to do further testing. We may have to test for resistance of the acting antiviral. So in that, and we may have to look at other reasons why the patient may not be responding as well. So in that case, we do recommend actually do not waste any time and refer the patient to ideally a liver transplant center. Now, if you don't have a liver transplant center close to you, then looking at your local GI doctor, adult GI doctor, or pediatric GI doctor, it's also a way to move forward as well. Next slide, please. So when we talk about the compensated cirrhosis, right, we need to know that there is a whole spectrum in this case. We talked about pretty much a symptomatic liver disease who we are concerned that has or is having liver failure or increased liver-associated mortality, especially those that where you notice ascites, hepatic encephalopathy in the patient, where he's having persistent upper GI bleeds, where you're seeing elevated bilirubin, low albumins, and elevated PT and INR times. That we're thinking more about that patient being on decompensated cirrhosis. If there's any type of respiratory issues as well, we may consider that as decompensated cirrhosis. Now, it's important to know that we have calculators to classify and predict the outcomes, but they should only be applied to patients with cirrhosis. And that's when the Child-Turcotte-Pugh score can help us a lot to see where we are. So next slide, please. Now, this one we talked about, if you have a patient who has a CTP score between 7 and 15 points, which category B and category C, then we know that that is actually predicting mortality on that patient. And now it's using actually assist doctors to predict the prognosis and liver dysfunction. We talked about that if you have a patient that you're actually evaluating and you find out that he has a CTP score of 7, above 7, then we recommend highly refer that patient to a liver center or a local liver center, because that patient may actually be having decompensated cirrhosis and may even require at some point liver transplants, tips, other type of interventions before starting treatment for Hep C. Next slide, please. We talked a little bit about when do we need to refer, why we think the genotype is important, and what are the things or what are the most common signs and symptoms to look for cirrhosis, right, or advanced liver disease. Now, what about treatment resistance? Because it can happen. Now, fortunately, it may not be as common, but as we start using more and more these medications, and as we deal with sometimes patients that may not be compliant, we may start dealing more with issues of resistance. And so this is going to be important in the clinical practice when the results will actually modify treatment management, because it's going to impact the duration of therapy. And we talked about that. Some of those will require not to be 12 weeks, but they're going to be 16 weeks or 24 weeks. Or when you're thinking about using or including ribavirin as an alternative therapy, because they have actually failed or show resistance to that. Now, the utility of RAs testing at this time varies by both patient characteristics and the regimen that we have. So that is something very important, although we don't do it on every patient who has failed for the first time. We do have the option to send this to the lab to get those. Next slide, please. And so this is an example just about what kind of regimen-specific or RAs testing we can do. We do have, and I'm not going to go that into detail because I think this is more just have the knowledge that we can actually do in NS5A RAs testing, and that can be especially considered for genotype 1A infected patients that do not have cirrhosis. and are being considered to get treatment with ledipasvir and sofosbuvir. Exactly the same thing. We can actually get specific testing, and this is according to the AASLD guidelines, where you can actually get RAS testing for genotype 3 infected patients that are treatment naive or treatment experienced, but they do not have any cirrhosis, and you consider them for 12 weeks of treatment. And so definitely this is something that usually, whether you send it to the lab so we can test for resistance, it can be done. Now, it's not something that commonly we're doing on pediatric patients, as they seem to responding really well if we are making sure they adhere to the treatment. But we do have the option to send those as well. Next slide, please. Okay, questions that we have so far.
While folks are thinking of questions, and feel free to come off of mute and ask your question or put it in the chat. I will say, Dr. Alfaro Cruz, you touched on a lot of really interesting things today. One of the things I think you were mentioning too, in terms of referrals, and not only that, like family care providers or pediatricians, what have you, can treat hepatitis C in these children, but kind of the nuances between referring and not. And so I think with adults, there are simplified guidelines for those with without cirrhosis as well as those with compensated cirrhosis. And whereas with children, as of yet, though, when I met not long ago with AASLD, I heard we might have some for pediatrics simplified guidance soon. And it is, as you mentioned in the details, in the AASLD and IDSA guidelines. But one of the things that comes to question is, if since cirrhosis is not very common in children, if you do see a child presenting who does have cirrhosis, even if it's compensated cirrhosis, would that be maybe an opportunity where you'd still want to consult with like a specialist or something, just because it's so unusual, would you think?
Yeah, so I think, most of the time, if a kid presents with cirrhosis, because it is so uncommon, and so it's not your frequent presentation. So that's a kid that maybe we don't have to wait, right? We want to treat for sure, but it's worth to actually refer that patient, because we may have to investigate other reasons why that kid may have cirrhosis as well. We have seen genetics, we have been seen metabolics, we have even seen very delayed diagnosed BAs or colorectal cysts that can be associated with that. So we really don't want to delay treatment, but we want to make sure we kind of figure out or investigate more of what potentially have contributed for that patient to have cirrhosis. So definitely I would say, if you have suspicion that that kid has cirrhosis or did present with cirrhosis, absolutely, I think refer, so we can start doing more of that workup and finding out if there was any other contributor for that.
Yeah, that makes a lot of sense. Anybody have any additional questions or comments they want to add?
And one thing that I always kind of want to talk about children is, remember, if you have a child that you diagnose with Hep C, talk to the mom about other siblings as well. Because that is something that we tend to focus more on the child who has Hep C, who has cirrhosis, but we forget that they have siblings as well. So it's always very important to talk to them, ask any siblings, ask when mom was diagnosed, when mom was treated, when does she think she got infected, right? Because a lot of the time, mom may not know that she got infected or have lost for follow-up. And so it's important to kind of, yes, focus on the child that you have in front, but also question about other siblings born to the same mom, in order so we can get tests ahead too.
Right, and that has a lot to do with is it that pediatric hepatitis C is often transmitted
Yes.
through pregnancy?
And it's usually because that's what most commonly is the most common form of transmission. It's usually intrauterine or vertical transmission. So
Mhm.
that's why it's so important. We don't tend to see as much, although we are scared, to be honest, that if the adolescents start using more IV drugs, or they start kind of going into sexual practices that are not protected, we may start seeing more of that. But right now, we know that the most common is the vertical transmission. So that's why we're focusing a lot on getting more history from the moms regarding any other siblings as well. We want to focus on the kid that we have in front, but we also want to be proactive about other siblings as well.
Makes a lot of sense. Thank you. Before we move on to our case presentation, any other questions?